Good afternoon. Welcome, everyone. My name is Melissa McVie, and I am the Education and Home Support Facilitator with OARC. Thank you so much for taking the time to participate in today's live webinar featuring the Patient Ombudsman, a champion for fairness. Before we jump in, I wanted to go over a few quick housekeeping items. Firstly, you'll notice that we've muted all of your lines in an effort to eliminate any background noise and distractions for our speakers today. This webinar is being recorded for education purposes and will be made available to you following the session. We have protected time for a question and answer period at the end of our speaker's presentation, at which point you can either unmute your own line or type into the chat box feature, which is located at the bottom of your toolbar. Today's webinar slide deck is also available to you under the materials section of the same toolbar. So without further ado, I'd like to welcome our two guest speakers today, Craig Thompson, Executive Director, and Elizabeth de Sousa, Senior Investigator with the Patient Ombudsman Office. Craig has more than 25 years experience working in the healthcare, design sciences, and communication sectors in various leadership roles at both public and private organizations. Elizabeth has over 24 years of experience in the nursing profession, including work in long-term care management, palliative care, and as a clinical investigator. So I'm just going to unmute their line now so I can hand it over to Craig and Elizabeth.
The other day, I didn't even know we had this one here.
Okay, Craig and Elizabeth, are you there?
Part of it.
Hello.
Hi there.
I don't know where it is. Bringing it to your office will make a difference.
It's like I'm hearing some other voices on the line.
The mattress in that room.
Okay. On my end, everything's muted. I've manually muted all lines.
We'll check it, and if we can make it, we'll leave. Not can we use this?
Can you hear us clearly? Because then we can try to speak over it.
Yeah, if no one else is hearing those sounds, we'll just go ahead.
Okay, I think we'll go ahead. Thank you.
Okay, well, thank you, Melissa, for inviting the Patient Ombudsman's Office to speak to the Ontario Association of Residents Councils. We're really pleased to take this time to introduce everyone to our office and what are the services and supports we can offer residents and their families, and a little bit of the background of what the Patient Ombudsman is all about and what we do. We're also going to touch a little bit on some of the data that we've been collecting over the 3 years that we've been opened, and give you a bit of insight into some of the things that we're learning about the healthcare system, in particular the long-term care system, but then really to put some sort of meat on the data is to talk about some scenarios that we see in long-term care settings that we think through the stories that we'll tell will help residents to understand what is the role of an ombudsman and where we can help. So with that, I'll get started. First, we wanted to talk a little bit about what is the Patient Ombudsman, and there's a lot of, I would say, lack of understanding of what an ombudsman is all about, and particularly what the Patient Ombudsman does. So we really wanted to spend a few minutes just talking about what our office does, and maybe putting some of the misconceptions that people have and trying to better understand what it is the office does for patients and residents. So we are in the business of receiving complaints. We receive and resolve complaints from a variety of healthcare sectors, and that's primarily what an ombudsman's role is to take complaints and, as early as possible, try to resolve those complaints working with the complainant and also the organization with which the complainant has the issue. We're always looking also to help patients and caregivers navigate the complex healthcare system that we find ourselves in. this was a sort of unintended consequence of our office opening, was that while we early on received complaints, we also received many requests for help from patients and families for helping them to navigate what is a very complex group of sectors when we go through our healthcare experiences. So that is one important point that we want to make clear to everyone, is that if you have a question and it may not even be a complaint, but you're not really sure who you need to call, then we welcome you to call our office and speak to one of our early resolution specialists, because they're very well prepared to be able to answer those questions. And if we're not the right organization for you to be speaking to, then we usually know who is the organization you should speak to. So an ombudsman is also referred to as an office of last resort, which sounds a bit ominous, but what it really means is that before you come to an ombudsman's office, you really need to have given the organization with which you have an issue or a complaint a chance to resolve that complaint. And that just makes sense from the standpoint of the best kinds of resolutions to a conflict occur between the people who have the relationship. So we're always asking that complainants have given the organization, the long-term care home, an opportunity to hear what the issue is that you have, try to get to make some changes to resolve the issue, and only after you've given that its due and you've gone as far as you can with that process, then you come to our office and we are then in a position to be able to help you. So that's what we mean by an office of last resort. We just want to make sure everyone at the point of care has a chance to be able to resolve a particular problem. Another misconception about ombudsmen and the work that we do is that we are not patient advocates per se. So we're not in the business of advocating for a position of a patient or a resident and only taking forward that particular position. We always want to look at what the complainant is saying, but also what the organization is saying. So we're really interested in walking that middle road where we give everyone an opportunity to talk about the issue in their words, and tell us how that issue is impacting them. And then after we've heard from both sides, then we're in a better position to understand truly what is happening and where there might be opportunities to find the common ground where a resolution might live. So that's a little bit of a misnomer that we have, that we're an advocate for patients. What I will say, though, is that we are there to help patients and residents when they have complaints or have issues with the long-term care system or the health system in general. So we're also often referred to as champions for fairness, and that also speaks to this concept of us looking for the middle ground. So fairness means that everyone has a chance to speak to a particular issue so that it's fully understood and everyone has a chance to voice their concerns. But fairness also has other elements to it, and that really is classic ombudsman work, where we look at an issue from the standpoint of fairness, and we have a methodology that we employ that allows us to take a complaint and break it down into its component parts along the lines of what seems to be a fair resolution. And fairness, these three areas that we look at through a complaint at are around the relationships, around the processes, and around the decisions that went into this complaint coming to be. So that's why we're often referred to champions for fairness, and there's more information on our website about exactly how we arbitrate what is fair and what is not fair. We also have, in addition to our ability to receive and resolve complaints, the power to conduct investigations. So investigations, while most think that should be probably the largest part of our work, is really not the biggest part of what we do. Investigations typically involve situations where a complaint might be a little bit more complex than we initially anticipated, and that requires us to go a little bit deeper. It also might have a broader public interest where there may be more than one, or by us investigating and really trying to understand truly what an issue is, we'll be able to help a lot more people than that single complainant. And also we will conduct investigations if there is a question as to what are the facts of the case. And we would be able to get better data if we're able to actually use our formal process of conducting the investigations. And Liz will be able to talk a little bit, I think, about that a little bit later in this talk about investigations, if you had questions about that. We're also ultimately in the business of making recommendations for system change. So the power of an ombuds office is that we listen to every experience, and it's within those experiences that we find the insights that allow us to recommend or make suggestions to the system to change things so that the next person doesn't have to go through what the complainant went through. So that's ultimately the power of the office and really what we see as our value proposition to the healthcare system. So as an ombudsman, we have a jurisdiction that we work within. We have jurisdiction over the 141 public hospitals, the 630 long-term care homes, and the 14 LHINs who provide the home and community care services. So we know that that is not the entire healthcare system, albeit it is a big part, it is a big portion of the healthcare system. We know that our experiences with the health system never cleanly fit within a sector. So we may start our healthcare experience with the primary care system, and then we may have an exposure to the public hospitals and the acute care system. And then we may, as part of that same experience, have an interaction with long-term care homes or home and community care. So when we see a complaint come to our office, while we have jurisdiction over these three major sectors within healthcare, we don't limit the listening that we do to those sectors. We always listen to the entire experience to make sure we fully understand what the complaint is about and what is the experience that the patient, the resident, or their families has gone through that brought them to our office. So I'll just make the point again, if you're not certain whether a complaint that you have about an experience within the system is relevant to our jurisdiction, I encourage you to call the office anyway, and our staff will be more than happy to help you with that complaint, either whether it's with us because it's our jurisdiction or whether it's with someone else. So as I mentioned off the top, we're in our third year of being open, or actually just moving into our fourth year. And in our first year, we delivered a report called Fearless, which provided the ministry and our other stakeholders with some data and some information about what we found in our first year of operations. Now, the reason we called this report Fearless was we really wanted to identify that complaining about healthcare, particularly in settings like long-term care, where these are intimate care settings, requires that residents and their families are fearless because no one really wants to complain about the individuals who are giving us care, because, as I said, these are really intimate relationships. We rely on them tremendously for their care and expertise. So complaining is not the first thing that comes to mind when we have a conflict. So we really wanted to make sure that we recognize that by coming to our office, complainants are showing a certain amount of fearlessness. And we really wanted to honor that and also recognize that that's what makes it very challenging sometimes to tell their stories. But there's another aspect of this word that we wanted to bring out by asking the long-term care homes and the healthcare system in general to have less fear of complaints. Because we truly believe that within a complaint, there is always tremendous insights and learnings that can be gained so that for the next person that comes along, they don't have to go through the same kind of issue that the complainant might have gone through. So by the system having less fear of complaints, we think that leads to a better environment for us to be able to exchange our insights and also for the system to change. In year 2, our second year report was called Fairness. And this report, again, highlighted what we learned in our second year of operation. And what we were trying to reinforce with our fairness title was that the work of an ombudsman is very much in the business of fairness. and that's why we're referred to as a champion for fairness. So fairness, in our report, we worked very hard to identify what fairness looks like within healthcare by telling certain stories that we had come across as part of our complaints process, and then talking about the work that we did as an office to understand better what the issues were that were at play and how fairness was, the bar of fairness was either met or wasn't met. And so we really tried to sort of to explain what fairness means within the context of the work of an ombudsman. So we are an organization that likes to collect data because we want to be evidence-based, and so we want to make sure that the information that we're receiving is properly communicated to the healthcare organizations and also the Ministry of Health and Long-Term Care, so that they can make use of it in the terms of quality improvements or improving processes. So I'm just going to touch very briefly on some of the year 2 data that we have and what we are hearing and seeing from Ontarians. So in our second year of operation, our office received 2,301 complaints. And so that was an increase of 16% from year 1. So 16% is a good, healthy increase year over year. And what that said to us is that we, since opening our office, we know that there's been a need for people to reach out to organizations like ours to talk about the issues they're having with the healthcare system, and also to ask questions about how to navigate that system. So I can tell you from our year 3 data that we actually are up to 2,412 complaints, so not as big as an increase from year 1 to 2, but we're also seeing a different kind of complaint in our 3rd year, and that I think is sort of an evolution of our office and the evolution of people's understanding of what our office can do. And so we look forward to being able to communicate more of the insights and information that we received in our 3rd year of operations when we release our year 3 report later this year. So we take our complaints in 2 forms. One way is we do it by telephone or in person, but we also can receive complaints in formal written form. So when we receive a complaint through the telephone, that's typically where we will begin to hear about the experience that the complainant has had. We find that the telephone is a really great way for us to be able to have a conversation and let the complainants speak about the entire experience so that we can get all the different details that we need. Ultimately, though, for us to take a complaint forward in a more formal fashion, we need to receive that complaint in writing. But we recognized very early on in the opening of our office that submitting a written complaint is in and of itself a barrier for some people. So while that is a formal requirement of our legislation, we are not held to receiving all complaints, formal complaints, in the written form. We have gone so far as to have people give us their complaint verbally over the phone, which we will then transcribe. We have received complaints through email, which we then follow up. But we recognize that written form is not always the most ideal situation for people. So we will take a complaint really in any way that we can to make sure that we understand it fully and that the complainant feels comfortable relaying the information to us. So a little bit about the data that we've received about long-term care homes. So this may not be the easiest thing to read, and there's a lot of information on this slide, but essentially when a complaint comes in, we take the complaint and we break it down into the complaint categories, we call them, so that we can understand what are the issues that are in play with the complaint, so that we can, first of all, help the complainant to understand better what it is that they're wanting to achieve out of bringing this complaint forward. But also when we communicate with the long-term care home or any other of the health sector organizations, we want to make it more useful for them to be able to take a complaint and see where within their operations this complaint might sit. So we categorize each complaint through a series of categories that we worked with Health Quality Ontario to develop and refine. And what you'll recognize is that each complaint is never made up of one particular issue. It's always multifaceted that way. So you will get a complaint that could be about quality care, but also about sensitivity, caring, and respect, or it could be about the complaints process and communication and engagement. So we try very hard to break a complaint down into those component issues so that we can make sense of it. But when it comes to long-term care homes, we received 214 complaints in year 2 about long-term care homes. And the top 10 complaints we received are what's communicated on this slide. So the first one is 25% was about quality of care. And quality of care speaks to poor or substandard care, or poor or symptom management or poor pain management. So that'd be some of the things that we might hear about if a complaint is about quality of care. The second greatest complaint we received in long-term care from long-term care was about sensitivity, caring, and respect. And so that is about the behaviors or the attitudes of the staff working with residents, maybe a lack of cultural sensitivity. It could be about inappropriate conduct, rudeness, or lack of attention to a patient's experience with care. So that would be some of the things we might hear about when we get a complaint that speaks to sensitivity, caring, and respect. It's important for us to also recognize that, particularly when it comes to the complaint about quality of care, if parts of that complaint are related to the clinical judgment of a registered, regulated health professional. So if the complaint is about the clinical judgment of a nurse within that long-term care setting, then that is not jurisdictional for our office, and that is clearly something that the colleges, the regulatory colleges, would have jurisdiction over. So in that situation, that component of a complaint that speaks specifically to clinical judgment would be referred to the College of Physicians and Surgeons, or the CNO, or one of the other regulatory bodies for those regulated professionals. It doesn't mean that we will not proceed forward with some aspects of that complaint, but when it comes to the clinical judgment, we're very clearly not jurisdictional in that area, and it's also, we're not in the best position to be able to make those judgments, and that is why the colleges have that responsibility. So another one of the complaints that we see, and this is pretty much across all health sectors, is issues around communication and engagement. So communication, I think, is intuitively an area where we would all understand that conflict can begin to occur if things aren't being communicated properly, if the engagement with residents and their families is not appropriate or substantive enough. Then you can readily see how that could make its way into a complaint and a breakdown of the relationship. So we see this quite often, and I've often said that our office is somewhat in the business of fixing relationships, because when the relationship breaks down, the communication breaks down, and ultimately that doesn't create any kind of, doesn't foster an environment where people can talk about what's not working and try to find the common ground to be able to come forward with a resolution. So we see that quite regularly in all of our complaints, and our staff do, I think, an amazing job of reconnecting people so that those relationships can be reinforced, because ultimately the best relationships are the ones you have with your care team, because they will be the ones that are there long after we're gone. And so we want to make sure that we always reinforce those relationships as best we can. So that's a little bit about how we see complaints coming out of long-term care homes. Again, 214 complaints out of our total of 2,300 complaints is not a lot. We traditionally see most of our complaints from the hospital sector, and that's really mostly driven by the fact that there are more interactions with patients and families in the hospital settings than there are in long-term care homes or home and community care. We also, though, recognize that in long-term care homes, it is not the easiest thing to complain about members of a care team, just because you are these are your homes, and it's generally, we'd all be very reluctant to want to complain about people that are providing care in those kinds of settings. So we recognize, again, the challenges for complaining within long-term care home settings. And that's also another aspect of why we feel residents and families have to be fearless when they bring a complaint to us, because we know it's not easy. So I just wanted to touch quickly that there are aspects of some complaints that we receive that require us to do a mandatory report to the long-term care inspections branch. And that's in suspected cases of abuse or neglect. So we have done this in 29 situations in year 2. We continue to do that in year 3. But some of the examples of where our office has had to make a mandatory report to the inspection branch include the misuse of a resident's money, staff conduct, and that would be around alleged verbal or physical abuse, or in the perception of neglect, and this was around wounds or incontinence care. So those are some of the examples where once we've received a complaint and had a chance to learn more about the issues that are being brought forward with the complainant, and we understand that there might be an aspect of a suspected case of abuse or neglect, we are required to make a mandatory report, and we've done it 29 times. So that's, with that, I'm going to hand it over now to Liz to talk about some of the spotlight issues related to long-term care that we think will help to talk about the stories that we hear in a way that will allow residents to understand better the role of our office and how we can help.
So as Craig has mentioned, spotlight issues are essentially case studies, and they're based on some of our more common complaints that are brought to the attention of Patient Ombudsman. And so we have 2 for you today. And if you do have any interest in finding out any more about some of the case studies we have, you can access those on our website at patientombudsman.ca. So one of the most difficult areas for patients and their families to manage is actually long-term care home placements. And so it can be difficult to make decisions quickly at a time when you realize that you need to look for a new home because you can no longer manage in the current place that you live. So we have received about 60 complaints about this, 36 related to the LHINs and 18 related to hospitals, depending on whether people are going into long-term care from the community or a hospital. The main issue that we find is really around poor communication. And so what that means is that usually people will feel that their own individual circumstances are not being taken into consideration during those conversations about discharge and transition into long-term care. They also feel that they don't actually have enough information to understand the consequences of the decisions that they are making. And so, for example, I'm going to tell you the story about Maud. Maud is a widow who was transferred to a long-term care home that happened to be 4 hours away from her family and friends. Because the majority of Maud's family and friends are seniors, they find it difficult to visit Maud more than a few times a year. And so the family was getting increasingly distressed at the fact that while Maud is deteriorating, she may end up actually dying alone within her long-term care home among strangers. And so the family had contacted the LHIN to talk about their concerns about how long it was taking to transfer Maud to a long-term care home that was closer to them. And so the family did contact the LHIN, but felt that the message they were provided by the LHIN was that Maud was actually not a priority for them because she was actually within a long-term care home. So Patient Ombudsman was able to help in Maud's case. We contacted both organizations involved. So we contacted the LHIN in Maud's present area, as well as the LHIN in Maud's family's area. So although the LHIN had followed all of their guidelines about placement and trying to set up a transfer, the LHIN did acknowledge that their communication could have been misunderstood to mean that, or to have the family think that Maud was not a priority, and that was not their intention. So what we ended up doing is both of the LHINs agreed to work together. And Maud's family was provided with additional information about 2 homes that were closer to the family that had shorter wait lists. So Maud is currently on those wait lists, and Maud is currently the next on the wait list for both of those homes.
So what we asked of, or some of the tips that we took away from this particular story for patients and caregivers, is to ask questions and, if possible, request information in writing. It's always better to get information in writing so that you can understand clearly what was said and what arrangements had been made. Also, if you're receiving conflicting messages, for example, if the hospital and the LHIN are saying different things, then ask to meet both organizations together. And we found that they're more than willing to do that, because ultimately getting a chance to be face-to-face with each of their counterparts makes for better communications overall. And finally, predicting wait times for a long-term care home bed is very challenging. LHINs can provide estimates, but there's always a variety of factors that affect how long you actually wait. So ask your care coordinator to keep you informed, and if they have suggestions to reduce your wait time. Some of the suggestions, though, we have for health sector organizations are to review the information available to families and to the public to ensure that the wait list process for long-term care home placement is as clear as possible. They can also provide a list of persons for patients and caregivers to contact if they have questions or concerns. They can also share how patients and caregivers can escalate their concerns if they're not satisfied with the information received. And also to finally make sure communications with patients and families are focused on them and their needs and not just the rules. It's never just enough to follow the rules. Those rules need to be communicated in a way that patients and families understand them and have a chance to ask questions.
So another common complaint for our office is about no trespass orders or visitation restrictions that are placed on visitors. We have received over 50 complaints about caregivers being unable to visit with their loved ones. And so the right to visit is included within the Resident Bill of Rights. And so instead of focusing on what led to the restrictions, Patient Ombudsman tries to look at the process for attempting to lift the restrictions. So for this example, I'll tell you a little story about Claire and her mother, Rosa. And so Claire had a no trespass order placed upon her after multiple emotional outbursts towards staff when she was visiting her mother. But Rosa's family was concerned about Claire not being able to visit because Rosa didn't speak English well and Claire would translate for her. So again, Patient Ombudsman was able to help in this situation. We were able to arrange a meeting between the leadership staff at the long-term care home and Rosa's family. An agreement was made so that Claire would and could visit with her mother. And so Claire agreed to visit her mother in a specific area at a time when staff was available to answer her questions about care. And Claire also agreed to ensure that she was speaking to staff in a respectful manner.
So some of the suggestions that we had for long-term care homes around issues like making sure that trespass orders and visitations restrictions are fair was to document details of the incident and the assessed risks. Also, we wanted them to ensure that there is a documented process for reviewing the restrictions and provide a clear explanation as to why the restrictions had been imposed. So they needed to describe the behavior instead of just naming the behavior. So again, this just speaks to having a process in place where the kinds of behaviors that are causing the problems are well documented so that people can understand exactly what it is that is causing the concern. Also, another suggestion was the specific conditions of the restrictions should be clearly explained and should be no more restrictive than necessary to ensure the safety of the patients, residents, staff, and visitors. So again, this comes down to communication so that the person who has the restrictions really understands what it is that they can or cannot do, and so they are aware of the kinds of behaviors that are causing the concern. And finally, we would want long-term care homes to consider and communicate what would be required to ease the restrictions. It's not enough to just apply the restrictions. There also needs to be a process to where those restrictions may be eased off.
And so now that we've shared some specific cases, and we do understand that there's many different ways to complain in the healthcare system and that this can be confusing, we wanted to spend some time to review some important information that you should know about making a long-term care related complaint. We also want to try to make our process as easy as possible for you by providing some tips. So I will start by explaining when Patient Ombudsman can get involved. I am cognizant of the fact that Craig has reviewed some of this, so I will be briefer in those areas. But Patient Ombudsman can help with your complaint after you have tried to resolve your concerns with the long-term care home first. And so some suggestions that we have are that we suggest that if you do have a concern, by letting the staff that's in charge of the unit on that particular shift know. So every home kind of calls this role by a different name, whether it's the charge nurse or nurse manager or assistant director of care. If you remain unsatisfied with the response, or you don't feel that anything has changed, then you can escalate your concerns. And so a way that you can escalate your concerns is you may consider submitting your complaint in writing to the director of care or administrator. And I just want to emphasize that these letters or these written complaints do not have to be complicated. And the majority of times, a simple paragraph or point form works best, where you simply just state that you want to complain, what it is you're complaining about, and why that particular circumstance had an impact on you, or why you're complaining. And so the home is supposed to respond to all written complaints in writing within 10 days. Now, a response does not necessarily mean that your complaint is going to be resolved within those 10 days, but it means that your complaint should be acknowledged, and if it's not resolved, that you should have some idea about what the home is doing to look into or addressing your concerns. And so if you then still remain unsatisfied with the home at that point, or you feel that nothing's been done to address your concerns, then you may want to consider connecting with Patient Ombudsman. And so you're going to hear us repeat this quite a few times, but I want to talk a little bit about submitting a complaint directly to us. We do have dedicated staff that will answer the telephone. If you are directed to leave a voicemail, someone will call you back within 1 business day. So this staff can answer general questions for you. They can also talk to you about your complaint specifically. They can let you know how to submit your complaint to us. And like Craig has mentioned, if we think another organization is responsible for your type of complaint, then we'll provide you with that information to make sure that you complain to the right place. We do prefer that complaints are submitted in writing. Our website, patientombudsman.ca, does have all the information that you need, including a copy of that complaint form. However, if you don't have access to the internet, then you can ask our staff to mail you a copy of our complaints package. One of the things we do require to look into your complaint is consent. And so in order for us to help, we need to have consent from the person who has the right to your personal health information. This person can be you, or if another person helps you to make your healthcare decisions, then this may be your substitute decision maker or your power of attorney for personal care. Again, consent forms are available online, but we can also mail those out to you as well. And so the other question that we often get is that sometimes in resident council, there will be a common concern that's brought up within a meeting. So the group isn't happy with the response that they've received from the home's management to a concern that they have highlighted, and they want to file a complaint together. Unfortunately, we cannot manage group complaints. We have taken complaints from groups. However, we do deal with each individual complaint independent to the others, even if the concerns are the same. And this is because we can't control how much personal health information we're going to need in order to resolve those complaints. And we don't want to be sharing somebody's personal information with somebody else that they haven't given us permission to share with. And so I will do this quickly because I know Craig's talked about some of the things that we can't look into. And so some of the professionals in long-term care homes have colleges that are responsible for regulating them, such as doctors or nurses. So for example, at times you may have a complaint about the medication that you were ordered by your doctor. Because this would be considered considered a clinical decision, Patient Ombudsman would not be able to look into whether the medication should have been ordered. However, if you're not sure if your complaint is related to a clinical decision, please call us, and we're going to emphasize this a lot, is that you can call Patient Ombudsman and we can guide you to the best place for your concerns. If another organization is looking into your concerns, the same concerns that you've brought to Patient Ombudsman, we also can't help you with this until that proceeding is finished. So for example, if you're in court or you have a complaint with the Ministry of Health Long-Term Care, then Patient Ombudsman will typically wait until that proceeding is finished to look into your complaint to determine if there's anything that we can do to help with. The other thing I do want to emphasize and talk about is we want to make sure our process is as easy as possible for you, and we want you to participate as much as you can. So it's important for you to tell us if there's any accommodation that you need. So sometimes people don't think of the simple things that can make our process easier. So for example, if you have issues with your eyesight, we can increase the size of the font in our letters. If you are having issues with your memory, we can send you summaries of our calls. We can set up regular update phone calls. If you have issues feeling drowsy, say after certain medication, or you have activities that are important to you, then we can try to call you at your preferred time. If English is not your first language, or you feel you can express yourself better in another language, then we actually have access to interpreters that are usually available immediately for us. And so even with this issue about our preference about getting complaints in writing, as Craig mentioned, we will also talk about other forms that we can accept complaints in to make it easier for you. So some other general things for you to know is that it's helpful for you to share with us the complaint that you provided to the long-term care home. As far as giving us any additional information or documentation, you are welcome to provide us with whatever you think is important to provide context to your complaint, but please know it isn't necessary. We will ask you for specific information or documentation that is relevant. And so the other thing that we do is we know that we can't go back in time. So even though we are looking at your individual complaint, sometimes it's difficult for us and we can't change what happens. So our focus then becomes on not only looking in and resolving your individual complaint, but also trying to avoid a similar occurrence from happening in future to somebody else. And so although we're talking generalities today, it is important to note that every case is different. So sometimes we can resolve a complaint with a phone call, and other times it takes a lot longer, especially if the way to fix the problem is to actually change the way that all the staff are doing something, such as through a policy or procedure or guideline. And so I do kind of want to sum up all of the ways that we do help. And so in most cases, we help you navigate a complex system. So again, if you're not sure who to complain to or how, then our intake staff that answer the telephones can give you the information that you need to make a complaint to the right person if it's not Patient Ombudsman. We help to repair relationships. We know that the environment in long-term care is unique in that because this is your home and you see the staff sometimes more than you see your families, you form relationships with people. Some people don't want to complain, and sometimes when people complain, they feel that the staff are going to treat them differently. So we help to mend these fractured relationships by facilitating communication between the home and you. We are neutral and impartial, so what that means is we listen to both sides and we help to determine what is fair and reasonable in a particular situation. And so the most important thing is that Patient Ombudsman is that every experience matters to us. So I will end with this. If you feel that your experience can be better, then talk to somebody about it. We will not succeed in making any change and having impact if you do not tell us about your experience. So I think that's where we're going to end it. I believe, Melissa, that we do have time to take questions as well. And our last slide does have our contact information for you.
Thank you so much. On behalf of OARC and everyone on the line today, thank you so much, Craig and Elizabeth, for providing such a comprehensive overview. I think you really helped to clarify the purpose, the scope, and the jurisdiction of the role of the patient ombudsman. So you're correct. We have about 15 minutes left that we can devote to questions from the group, and I've seen there were a number that have come through when you were speaking in our chat box here. So I think we kind of touched on this, but there was a question from Brent. How does the patient ombudsman work vis-a-vis the long-term care complaint line? So I think this may be comparing when you would call one or you utilize the ombudsman service.
Yeah, sure. So I think, Brent, you're referring to that slide that Craig talked about mandatory reports. And so sometimes we have individuals that call us through our intake line and they start explaining their particular complaint. And so we are obligated to make a mandatory report, similar to the way homes are, if there is any kind of suspected abuse or neglect to a long-term care home resident. And so we have that obligation. We will ask for permission of that particular caller to send a lot of details, but we have to make that report, and we do make that report. Sometimes what happens is a complaint is not always simple, and so there may be aspects of a certain complaint that we can handle that might be more administrative. However, we respect the fact that the Long-Term Care Home Compliance and Inspections Division has more enforcement powers than we do. So if there is suspected abuse, we want to allow them to do their work first. We will often tell the individuals that complain to us that once that process is finished, if you allow us and give us the results afterwards, if you remain unsatisfied and you want us to take another look at it, that's the time to bring it back to us, and then we can kind of assess if there's any other areas that we can help with. Does that answer your question, Brent?
I haven't seen any.
Sure.
Oh, yes. He says there is a province-wide 1-800 number to call in complaints directly to the ministry. Yeah, I think that's
and so that's the action line. And so, oh, I see. I think I know what you're talking about. Because of the unit-based complaints, because of the written complaints, that yes, there is also the option to contact that action line as well for any kind of suspected complaints about abuse or neglect. And so the focus of the Compliance and Inspections Division is to ensure that the long-term care homes are compliant with the Long-Term Care Home Act and regulations. So that is their focus.
okay. The next question from Wendy: what is the timeline from the complaint being submitted to you and the resolution on average? I know this is probably a tricky one.
Yeah, so on average, I would say around 4 months. And like I said, I alluded to the fact that every case is unique, and that sometimes we can resolve something with a phone call and other times it takes longer. And so there are times when long-term care homes are actually changing policies or changing their entire program related to something. And so sometimes what we do is we will get that commitment from the long-term care home that they're looking into it. We will provide the long-term care home with the space and allow them to deal with those things locally, and then do follow-up calls afterwards. So that way the complainant's not waiting around to kind of know the end result. So we resolve it, we get the commitment, that is the resolution, and then our office will follow up 4, 5, 6 months later with the long-term care home to ensure that they kind of fulfilled that commitment. But on average, it's about 4 months on or off. Our intake, sorry, there is a separate, I'm sorry, Craig just looked at me because our intake line is different. So if we get the stuff that comes through our intake line is resolved on the spot, whether that's where do I make a complaint, whether that's how do I submit a complaint to you, is this the appropriate place, that gets resolved right away. What I'm referring to is the more complex written complaints that come to our office.
Great. I think that's a clear response. Thank you. Another question came from Mike, And I think he's referring to a table that was on one of the earlier slides that outlined the 214 complaints that came to you specifically from long-term care homes. And he's asking, how does the alleged abuse category that you've captured differ from the personal security and safety category?
I'm just checking, I'm just looking up, we have what we call a data dictionary that actually explains the nuances of these categories. I'm just looking for the...
Oh, it's personal. He's saying the 10% alleged.
Yeah, so the under the alleged abuse, where is it? Here it is. That's alleged verbal, physical, or financial abuse by a patient, resident, caregiver, or staff. The other category that we talked about, which was the personal security or safety, talks about falls, accidental injury, the environment or events alleged to threaten safety. So they're similar but different, and that's one of the challenges that we find with taking a complaint and trying to break it down to its pieces so that we can get the evidence to be able to relate it to our stakeholders. Sometimes it's not a clean category that a particular issue falls into. So it's a little bit of an art and science to actually code a complaint. I don't know, I hope that helps.
Yeah, I think that's great. And another question came through about accessing your slide deck. And as I mentioned at the beginning of our session, in your go-to training toolbar that's on your screens, there is a materials section, and the slides today have been saved as a PDF for your reference. So feel free to print and have that for your reference. Another question from Andrea: where are the scenarios and the second year report available on your website? Andrea is unable to locate the report, and I'm not sure if she's referring to the scenarios in your presentation today or.
So we can actually provide that to you as a link if that makes it more helpful.
Sure.
In the search bar on the website, you should be able to bring up spotlight issues.
Okay. So
however,
spotlight issues.
If you're having, if she's having some difficulty with that, we're happy to provide that link to make it easier.
Excellent. So I'm just looking down here. There's a few more that have come in. Can a long-term care home make a report to your office to help mediate with a family member when all other efforts have been exhausted, tried, and been unsuccessful? And I think you did in one of the spotlight or the scenarios kind of alluded to some mediation that had happened.
Yeah, so our legislation says that we accept complaints from patients or former patients or their caregivers. And so we have to date not actually had accepted complaints. We do have sometimes, we will get intake calls from leadership in health sector organizations kind of asking what to do in a particular scenario. I think what I would suggest in that case is that if the home and the family are both recognizing that there are challenges, then I would actually get the home to encourage the family to file a complaint with our office. And then we can kind of go from there and look at what resolution efforts there have been and what may be reasonable to try to resolve those complaints when escalated to our office.
Excellent. Another question that's come through from Carol: is there a difference in the number of complaints you're seeing from for-profit and non-profit long-term care homes, or is it, I'm not sure if you even capture that kind of distinction, or do you find it's the same?
It's a good question. We don't, because we don't have the data at that granular level. So we, 241, I think it was, complaints from long-term care is really not a a big enough data set to be able to come to any conclusions like that, and we're not really tracking complaints with that particular lens on it. So we don't have that information.
Okay. Are there any other questions? Anyone who's still on the line who'd like to unmute themselves and ask a live question for our speakers? So I'm not sure if we covered this. This is a question that was kind of hidden in between. There was asking for distinction between the long-term care action line, when to call them versus your office is the question. And I think that you said that when in doubt, reach out to you and the team can help triage and redirect the call when there is that confusion.
That's fair, and I do know that the action line will do the same thing as well. So they'd be available as well. But we are happy to receive those calls. We're happy for people if they're not sure to call us. And like I said, a big part of what we do is that navigation piece and that referral piece. So whenever in doubt, please give us a call and we would be happy to help sort that out.
Great. I haven't had any additional questions pop up on my end here. And I feel that there's been a lot of information shared today, but I really do appreciate both of you for taking the time to be here as a resource and to provide this important information and points of clarification for our audience. And the information is on your screen currently. If anyone on the line has some follow-up questions, please feel free to reach out. Oh, there is one more question. I spoke too soon. From Linda, when a complaint's in long-term care, do you always forward these to the ministry or do you deal with it yourself? Oh, so I think you talked about that distinction.
Yeah, and so like I said, we handle the majority of the complaints that we get related to long-term care unless there's an element that has suspected or alleged abuse or neglect of a long-term care home resident. And then, like I said, we would forward that to the ministry.
Okay. Well, I think we're just a minute shy of 3:30. So thank you again to our guests for that informative presentation. We look forward to keeping in touch, and we also wanted to plug in our fall-winter edition of Seasons magazine, which is set to come out mid-October to every long-term care in Ontario, and will be available on the OARC website. We do have an article authored by the Patient Ombudsman with some similar information talking about in what cases the Patient Ombudsman Office would get involved and wouldn't. So stay tuned for that article. And thank you so much for this exciting collaboration between our organizations.
Thank you so much, Melissa.
Thank you.
Okay, bye.
Thank you so much.
Thanks.